Okay, welcome everybody. This is our first monthly rounds of the year for Alberto Sono. I decided to just first maybe start the rounds with a talk about some physics, some kind of key principles to keep in mind when you're doing ultrasound. So if you want to participate, which I'd encourage you to do, just scan the QR code, or alternatively, whip out your cell phone, put in menti.com in a web browser and put in the code. This presentation, I tried to make it as interactive as possible so everybody can participate and answer some questions. Should be a fun time. There is a leaderboard, so, there's that too. Okay, and it's in the top as well if you have any further questions. So of course, when I say physics, I think everybody has this conception that it's going to be somehow complicated. And in some respects it is, in other respects it isn't. It is just sound waves in some respects, but of course it's passing through different materials with different physical properties, and that's where it gets more complicated. But if you understand the basic principles of looking through soft tissue and fluid and bone, for example, it starts to kind of make sense and really helps you understand why images are generated the way they are and what the limitations are. So hopefully this doesn't bore you all, but my hope was to make this interactive and to make sure that you guys feel like you're part of this, to kind of keep you alert and fresh. Now, while physics may seem unexciting in ultrasound, as I mentioned, it can be where the rubber hits the road. There are certain calls that are difficult to make, but understanding how an image is generated and the potential pitfalls and confounders is really important to troubleshooting image generation, acquisition, interrogation. But effectively can prevent erroneous conclusions and life-threatening diagnoses like aortic dissection, and you can better critically appraise findings and also give practitioners a framework to troubleshoot nagging problems. So certainly if there's a finding that seems unanticipated but doesn't appear to be anatomically correct, it helps you kind of troubleshoot those issues. So at the conclusion of the session, I hope participants should be able to use key principles to physics to understand image generation optimization and anticipate key problems with respect to physics. So some of the basics. So what relative frequency is best for interrogating superficial vascular structures? High frequency, low frequency, middle frequency, or I have no idea. Okay, so high frequency sound waves are typically the best for interrogating superficial structures. Short wavelengths, as you can see up here, wavelength from peak to peak, have high resolution, but because it's high frequency, it actually has fairly poor penetration, and high frequency sound waves have pretty poor, have actually high amounts of attenuation. And attenuation means a drop in amplitude at depth or basically energy. And so you just don't get very deep, but you do have a very, very high quality in the near field. Now, lower frequency, longer wavelength, again, peak to peak, better penetration, but decreased resolution. So you get deeper, like, in the liver here, for example, or in the heart, but you have decreased resolution. Okay, so that's just again, a key principle. So when you look at the lung, for example, you can often use curvilinear phased array, and it will give you, in select patients, a decent view of, say, the pleura, but occasionally you have to switch to a linear probe, which gives you better resolution to resolve any problems with the pleural line, for example. So African sound waves generally better near field resolution, but undergo high rates of attenuation and penetrate into tissues less than lower frequency. So we have a question. How do you increase the speed of sound traveling through a medium? Increase sound wavelength, increase the medium stiffness, increase medium density, or increase sound frequency. Oh, look at that. That's a really hard question. So the medium determines the propagation speed. The speed of sound is actually fairly static within a given tissue, for example. Like within soft tissue, it's around 1540 meters per second. Within air, it's around 300 meters per second. So with lower density materials, okay, the speed of sound increases, and with higher stiffness. So for example, within the bone, The bone itself has very low density, but high stiffness. So things like you've heard of bone conduction headphones, for example, are really good at conducting sound. That's because of that issue with high stiffness but low density. And so, but regardless of the frequency, all sound travels at the same speed through any select medium. If you increase the wavelength, then you decrease the frequency with no effect on propagation speed. And sound travels faster through bone, as we talked about, than lung, as bone is more stiff and less dense. So lung is obviously filled with air. And so this propagation speed you're talking about is mainly because of that problem with the alveoli being filled with air. Another question. What remains constant at increasing depth? Intensity, power, frequency, or amplitude? Okay, so at depth, frequency remains constant. The pulse duration period and axial resolution do not change with depth, but your amplitude does go down. That's why your signal becomes less bright as you go from near field to far field. And your power is your square of amplitude. So of course, power goes down. And if your intensity is power over cross-sectional area of the beam, then of course your intensity falls. So really, it's just your frequency remains constant. Okay, you perform an ultrasound on this patient, post-central line insertion. What happens when the sound wave penetrates the chest wall? Okay, so there's your lung ultrasound here, applied to the perisagittal plane. So rib, pleural line. So what do we see here? Does this demonstrate sliding in A lines? Demonstrate an absence of sliding? In the absence of sliding with B lines, or unclear? Okay, yes, so this is an absence of sliding here. So rather than having a tissue lung interface, it's now a tissue air interface. Okay, which you notice is if the lung is filled with air, it's actually a subtle difference. Okay, but there is obviously no kind of scintillating artifact here that represents lung sliding. So you discovered pneumothorax, or what appears to be a lack of sliding. What happens when a sound wave encounters air within soft tissue? The wavelength increases, the wavelength decreases, it's unclear, our frequency increases. So wavelength decreases. The propagation speed within, as I mentioned before, within air is much less than, say, soft tissue. It's about 300 meters per second versus 1540. When you see reduction in speed, you'll see reduction in wavelength as well. So that's kind of critical in that respect. Now, attenuation is a decrease in amplitude and intensity as ultrasound waves travel through tissue. Pick the best frequency for the selected depth. And the scale is from low frequency to high frequency. And these are the following different modalities of ultrasound, from vascular to surface cardiac to TE to abdominal ultrasound. So what would be the best selection here for frequency versus modality? And just sliding bars on your phone. Okay, nice. So the top there, vascular ultrasound, high frequency, of course, we talked about earlier on. Surface cardiac, of course, if you use high frequency, you get too much attenuation, so it doesn't work all that well. So it has to be a bit lower frequency. Of course, the way that the probe works in a phased array versus a curvilinear probe for abdominal ultrasound is a touch bit different in terms of how the sound waves are passed. And TE, of course, is a bit higher frequency. Now, how can TE be higher frequency but surface be lower frequency? Can anybody speculate? You're closer. You're closer, right? Exactly. There's minimal tissue between the probe itself and the heart. So you can actually afford to use a high frequency probe. That's why in general, the resolution is much higher, because you're not going through the chest wall and can use higher frequency sound waves, better resolution. And of course, abdominal ultrasound, being that it's deep in the abdominal cavity, you need lower frequency. So attenuation is proportional, and it's the square of the sound wave frequency. So higher frequency, obviously much more attenuation. High attenuation, low depth, low frequency, low attenuation, higher penetration, and kind of as we just talked about, vascular ultrasound, high frequency, surface cardiac, lower frequency. TE is marginally higher, but still considerably higher, even as high as 8 megahertz. And then abdominal ultrasound, considerably lower. But of course, you can use, in cases where structures are deeper, for example, in some patients who are morbidly obese, you may have a hard time using vascular ultrasound because of the sheer depth, which means if you have a depth of, say, 5 or 6 centimeters because of soft tissue, then you may actually have no choice but to use a lower frequency probe. And that's purely because of the depth problem. Okay, so occasionally we do use abdominal curvilinear probes for their low frequency in patients who have, large amounts of soft tissue. Your patient's unstable. UNECO, what is the yellow arrow pointing at? Pleural effusion, pericardial effusion, mirror image artifact, or I have no idea. Okay, so technically, it probably is actually a bit of both here. Like, I think some people said pleural effusion, and that's probably correct here because there actually is a pleural effusion there. But now, of course, what the arrow is pointing at is, what appears to be this other structure. So this is a mirror image. The pericardium, much like the diaphragm, likes to play a lot of tricks. Okay, and typically, this is what's called a strong reflector. And so it's creating this alternative reflection, which is just a mirror image. And, another common one is appearance of liver tissue above the diaphragm or cephalad of the diaphragm. So, of course, this patient cannot have two hearts. It's just, an improbability. So that's certainly a reflected structure. You can tell, obviously, that this looks like myocardium. But, of course, there probably actually is a pleural effusion. So both can be true. Any questions on that? Wherever you see bright, thin objects, like I said, the pericardium or the diaphragm, or even some parts of the heart, just be very leery that mirror images can show up. Here's another example. Yeah, it can be quite stark. Again, that pericardium, you can see all these are called ring downs from the pericardium itself. Again, very, very bright. It does not necessarily correlate with how much calcium there is, but of course, if it is calcified, it can be very, very bright, but it's not like there's necessarily that much value in how bright it is, per se. Now, if you change the angle of the acquisition, you'll likely see this disappear. Okay, because usually this is incidental. It depends on the angle of incidence of the sound wave striking the pericardium. For those of you who want to read more about artifacts, this is a great paper in 2016, Bertrand et al. They do a really good job of covering these artifacts. Other examples here, you might notice this is a subcostal acquisition. So there's the liver, okay, and there seems to be like there's two beating structures side by side, okay? But you notice these are side by side, not one over the other. So this is not a mirror image artifact, okay? This is called a refraction artifact, okay? It's how the beam is passing through the tissue, but often you'll see duplicated structures along the vertical axis. Here's another very, very common example, okay? It's kind of pointing to this here, okay? You may actually look at this and say, well, hold on. So just for those of you maybe who are learning this is a transesophageal echo image, left atrium, left ventricle, mitral valve, aortic valve, and aorta, okay? And so often, if you're looking for dissection, for example, you're looking for a flap that's post-valve. Now here, there's this linear area, which may make you think there's dissection there. But the issue is that commonly, what happens is there's the main part of the beam on an ultrasound probe, and there's often side beams too. Okay, and these side are grading beams, or they call them side lobes or grading lobes, can generate these alternative, basically duplications. So this is being duplicated over there. Okay, and it's often makes an arc. Okay, and I'll show you an image why that happens. So this is a grading or side lobe artifact that's very, very common in the aorta, especially when you see these very strong reflectors. So here's an example, the arc of the image. There's a side lobe, it catches it there. Main beam catches it, another side lobe catches it, and you get these basically arc of what appears to be similar looking structures. The key is that they're on the same plane. So if you draw an arc, they're always along the arc. So in dissection, this is a particularly important one because it's just so common for a side lobe artifact to give you this issue. Question 4, yeah. Name the artifact responsible for the appearance of LV thrombus in this apical four-chamber. Reverb, near-field clutter, acoustic shadowing, or ring down. Okay, so near field clutter, very, very common, especially in these apical views, gives you this false appearance of an LV thrombus because it's very, very hazy in the near field. Now, these have been, for a long time, it's been contentious what these actually are. And for a long time, it's thought that these were high amplitude oscillations of the actual transducer itself. In all actuality, they're probably just a reverb artifact. Now, there's what's called harmonic imaging technology, or tissue harmonic imaging is one way to reduce this artifact. It blocks the kind of emitting frequency, or what's called the fundamental frequency of the probe, but allows for additional resonant frequencies. You can often change the probe position relative to the apex. So if you go a little bit past the apex, for example, then it can reduce this artifact greatly. But the point here is to recognize this is just such a common problem that it's easily missed. And you could say, even if there was a thrombus here, you probably necessarily wouldn't always see it because of this artifact. So often, if you call for a comprehensive echo from the echo lab, you may have to ask that they actually do contrast for thrombus. Now, occasionally they'll reach out and say, you know, we have a suspicion of a thrombus, and so we like to use contrast, but not necessarily always. So always think about that, because, you know, as you can tell, just because you can't see it doesn't mean it's not there. Albeit with LV thrombi, usually, okay, there'll be a wall motion abnormality like hypo or akinetic. So in this here, this is a very awkward two chamber. It's kind of done a certain way to highlight the thrombus. So if they have a high pretest, you know, they have a severe anterior wall apical and apex that's not well functioning, then of course they'll say, well, this is suspicious. With the near field clutter, we just need contrast. But occasionally you will see a, you know, very obvious 2D discrete mass with clear margins. So it really does depend on some degree of pretest if their wall functioning is extremely poor. So just be aware that if the LV function is extremely poor, there are actually some subtleties to detecting an LV thrombus that oftentimes it may just be hard with conventional, you know, point of care, and they just need a more comprehensive investigation. So, you know, and like I said, oftentimes you might do non-conventional views, off-axis views that just reduces the clutter and reduce some of the artifacts that can happen. Okay, but you can see here on this wall is poorly functioning. There's this big kind of lobular thrombus there. If that thing busted away, this person would be in a great deal of trouble. Color Doppler. Okay, so color Doppler highlights regular and irregular blood flow. So normal blood flow is blue away from the probe, okay, and red towards, okay, and that basically the ultrasound probe emits a certain frequency, and then there is a receiving frequency, and it looks at the frequency shift and it detects an overall, it produces an overall color change. Now there is a scale. This scale is important. Okay, that's if this is 0, then above the scale is 60. Okay, so that's 60 centimeters per second. Okay, a normal velocity in the heart is somewhere between, you know, let's say 30 and sometimes even 200 centimeters. So this is a pretty common kind of 60 to 70 centimeters, pretty common calibration or standard setting for color Doppler. And so usually if you're in that 60, your color Doppler gives you a red or a blue. Okay, and you can tell here that during diastole, there's that red blood flow towards the probe, which makes sense, right? Now, if you exceed that velocity, if you go past 60, let's say toward the probe direction, then you get what's called aliasing, okay? And that means that the machine no longer knows exactly what direction the blood flow is going, and then produces a mixing of colors. So you can see that in the center of that diastolic flow, it's maybe just a tad faster. You guys see it's not all red, there's some blue in there. And so that means you've exceeded this velocity. Okay. Now a common example would be, you know, if you look at you know, an iPhone recording a TV, for example, or a video recorder recording a TV, and the frame rate's being mismatched, right? Or for example, you're watching a prop on a plane that's spinning, and once it hits a certain frequency or revolutions, you stop being able to track what direction it's going. That's because you're not sampling enough. Okay, we got to basically sample twice per revolution, okay, per wavelength, to really understand what the velocity and direction is. Okay, so if you exceed that, it's called aliasing, where you see a blossom of color.
So if you just adjust your, like, increase your scale, that'll go away.
It could go away if it's adjusted enough, right? Because obviously, like if your velocity was say 80 towards the probe and you put it to 100, yes, it would go away. But if your velocity was 80 and your max scale was 70, you'd still see it, right? I think that makes sense. So oftentimes there is a max actually on that limit. Now that number is called the Nyquist limit. Okay, that's the actual name for it, is Nyquist limit. So that Nyquist limit does have a maximum it can calculate. And so I think on our machines here, it's around 80, I think, at most. So you can't usually go past 80, okay? And nor would you probably want to, because you're actually, you'll see here, we actually use that limit to look for acceleration of flow, okay? So, you know, for example, this aliasing, this mosaic of color is what catches our eye. So you can see that there's this jet here that's showing up, right? And it's not in the direction we expect, because blood, of course, should flow from the atria to the ventricle. This is the right atrium or ventricle. And some of it is very, very quickly, but then there's this jet going backwards, okay? So this is us picking up this aliasing, okay? You can see here that it is blue mostly, but there's also some mix of color there at the start. And that's because at the neck of this jet is very, very fast. Okay, there's obviously regurg here, right? Can everybody see the regurg there? So at the neck of this jet is the fastest blood flow. Okay, it's going very, very fast. It's exceeding this velocity in the retrograde direction. That's why it's color mixing. But then as the jet expands, it slows down and it's a little more blue. Okay. So this is what, you know, color Doppler is essentially an alias detector. That's all you're doing, is looking for when does the blood flow exceed that velocity. But of course, you need to be mindful of what that velocity is. So for example, if you reduce this, let's say it's +10 to -10, what do you think would happen? It was +10, -10. You change that on the same heart. It'd be like very, very bright, right? Like a big signal, like even bigger. Well, so it may become even just more pronounced, but may also become very noisy, as I think you're kind of intuiting that all of a sudden the signal is much brighter and much bigger and hard to separate. Yeah. So here's an example in the aortic valve. So there's a mild regurgitant jet, and there's like severe, okay? Now, notice this velocity is appropriate. It's about 64, okay, positive and negative. So it means that you're not over emphasizing the signal. It's just there's a lot of signal here, right? Like it's so much, the blood's almost to and fro. So that's where, when you have very severe valve disease, it can be actually kind of hard to separate the signal because it's just so much signal. But this is like the classic example where this patient would have a rip-roaring, diastolic murmur. They'd have flow reversal. That blood is just going in the aortic valve and spilling right out. So why is there mostly a black signal in the area of this white box? So this is a blood vessel, some red here, but there it's kind of red. Sorry, of black. Okay, great. So presence of flow, angle of Doppler interrogations is perpendicular. Okay, so your probe is right here over the vessel, and you're applying color in this direction. So there's obviously flow across the vessel, and best way to interrogate flow is 0 degrees or parallel to flow. So if you could somehow place the probe here and orient it this way, that'd be the best way to get that flow. But of course, you know, in the human body versus ultrasound probes, generally most vessels are going to be perpendicular. Now, in vascular ultrasound, you can correct the angle as much as 60 degrees with one mode of Doppler. And in cardiac ultrasound, generally less than 20 degrees is acceptable. Any greater than that, it becomes less reliable. But the Doppler shift is directly related to the cosine of the angle between direction of flow and the direction of sound. So a cosine of 0, that's 0 degrees between your interrogation angle and flow, equals 1. That means your calculated shift is the full calculated value. But if you're 90 degrees, interrogating this way and flow is this way, cosine of 90 is 0. And I think this diagram probably describes it better than I just did. But basically, frequency shift times velocity times cosine of the angle. So if your cosine is 90, you're gonna get no signal, okay, because you're just 90 degrees. So of course, the way that we often have is in heart and vascular ultrasound, often we're trying to minimize that angle between how you interrogate and the blood flow. Is there questions on that? What is most likely being adjusted moving from screen left to screen right? Increased color gain, increased Nyquist limit, reduced Nyquist limit, or no change in Nyquist limit? Okay, nice. Yeah, so here, if you actually look closely, it kind of tells you in the picture actually, 60, 33, 18. So actually the Nyquist limit is being adjusted downwards here. And this is what I mentioned earlier. So I'm trying to repeat some things just so I kind of get some, some impressionable memories here. But basically, as you reduce the Nyquist limit, that signal becomes very loud. So just to really emphasize with color Doppler, you have to be really careful on how that Nyquist limit is set. So like I said, in the heart, typically we're at 60. In blood vessels, we're often at like, say, 10, for example. But you can tell here, if you misapply the color scale, a jet may look far more impressive than it really is. Okay, so always check the color scale when you're using color Doppler. And if you, for example, use 60, and we're looking at a vein, for example, a blood vessel, okay, then you may see very little color change, okay, because your color shift is very, very low. Okay, so if you look at a blood vessel, for example, even the IJ with the scale of 60, you may see very little because, of course, the velocity is small. And so the frequency shift would be very small. And it may fall within that almost, cosine kind of 90 in that very small degree in shift. So just be mindful of this whole color scale Nyquist limit problem, because that really comes down to how much you can amplify that noise. Now, color gain can actually do something very similar. Okay, color gain can amplify a signal. Okay, and it could actually look very, very similar. Color gain basically it's just like your conventional gain on ultrasound. It amplifies both signal and noise. And so if you increase the color gain, you could get a very similar signal. And once on our machines, once you put on color Doppler, there's a slider that goes in the screen and that will adjust your color gain. Okay, but oftentimes I would say it's very infrequent that I even touch color gain. And often if there's lots of noise, for example, like sometimes, hyperdynamic hearts, tachycardia, and there's just so much noise, then you can turn the color gain down just to reduce some of that extra noise. Okay, but it's normally not often used. Yeah, exactly. If you're trying to really amplify noise, for example, and this is color Doppler. Okay, there is another mode of Doppler that can be used to detect flow. Do you guys know what that would be? Another mode of color called power Doppler. Okay, power Doppler is different than this. Okay, power Doppler was specifically made. It's got no vector. It doesn't tell you that it's coming to or going away from. It just tells you that there is flow. That's all it tells you. Okay, but it's very, very, very sensitive for flow. Okay, that's the main application. So oftentimes, I think the application that I'm probably most familiar with, although I don't do, is testicular ultrasound for torsion, because it's just very, very sensitive to flow. But again, won't tell you vector. It'll just tell you that there is flow, in fact. Our machines here, if you press color Doppler, then along the side, you may not notice, but there's what pops up is basically color Doppler and then power Doppler. Okay. So if you're ever time just thinking, is there flow? I don't care about direction. Just power Doppler is very, very easy. So of course, all you're seeing here is that as you adjust the Nyquist limit down on both tails, then you're exceeding the Nyquist limit to a much higher extent. So blood is whizzing past the Nyquist limit. This 65-year-old male with refractory shock and plus aliasing. There'll be a question right after this, so just take a look. So there's a lot going on here, okay, but I'll let you guys just, drink it in for just a little short time here. What is causing the aliasing and the LVOT of this patient with refractory shock? High output failure, hyperdynamic circulation, systolic anterior motion, or no idea. So while aliasing can happen with regurgitation, it can also happen with stenosis, okay? So, the reason why blood flows up at regurgitation is because obviously it's a small leak in a pressurized chamber, but of course it happens in antegrade flow too. So if the valve is stenotic, okay, then you'll see flow acceleration or aliasing. But in this case, it's not necessarily across a valve, it's across the LVOT. You see blood's really speeding up here, okay, really speeding up. Now, if you look here, what's going on there? Sam, right? Nice. So that anterior leaflet, that's posterior leaflet, anterior leaflet, when the valve closes, i.e. systole, it bangs against that interventricular septum, okay, and is creating dynamic obstruction, okay? That obstruction gets even smaller as systole progresses. Of course, whenever you have treatment refractory shock, this should be on your list of like maybe the inotropes are making things worse. Now, this example here is actually a case of hypertrophic cardiomyopathy, but people oftentimes associate these two very strongly, but there's a lot of problems that can do this. LVH, for example, hyperdynamic basal septum, like in an infarct, for example, like an anterior infarct, you can see this. Takotsubo, oftentimes you'll see a hyperkinetic basal segment. These can all do this, okay? Even just a funny sigmoid septum with enough inotrope. So just be mindful that you don't need to have HOCM to have obstruction. You just need the right conditions, in fact, for most patients. I've seen a lot of systolic anterior motion the last couple of years, and I think one case was HOCM out of like 10. Okay, so it's actually not, there's tons of other causes of dynamic obstruction. It's just that HOCMs are most commonly associated. But the tip here is aliasing through the LVOT. And then this as well, right? Did you guys catch this? What's that? Eccentric mitral regurg. Exactly, eccentric mitral regurg. And why is that important in combination with aliasing through the LVOT?
There'd be something wrong with like the mitral valve annulus that's also causing SAM.
Not normally, but just think about what's happening to this valve. It's getting pulled open. Yeah. So this eccentric MR, very, very common systolic anterior motion. Okay. It's like once you see this and you see that, you can almost be like, it's SAM. Because like just that combination of problems, flow acceleration, eccentric MR, just that should be your first suspicion. And because SAM is like, it truly can be a visual diagnosis. You're like, oh, I see. When this valve shuts, it's all the way over there. It's like, okay, that's pretty obvious. Okay, so just as somebody kind of cue you in about those signals. So flow accelerating there, most likely to be systolic anterior motion. So summary take-home points. Ultrasound and physics and point-of-care imaging go hand in hand. We talked a lot about kind of frequencies and resolutions and attenuation. We talked a lot about different artifacts, like mirror image artifact. We talked about reverberation artifact, refraction artifacts. We also chatted about color Doppler, aliasing in both regurgitation and obstruction. So I know some of these concepts may be perhaps fairly new to some of you, but I hope for those of you who are both learning and also getting new knowledge, it was similarly useful.